stands for, again, spine, technology, education. The D is for discovery, discussion, debate. We are privileged to have Dr. Liz Lord here today from UCLA. She's an accomplished spine surgeon who is going to talk about what it means to take on big cases in the beginning of a career. And that's a very emotionally and mentally challenging topic. And I thank her for spending her time, dedication, and input with us. Reflecting back, last Saturday, we had a very cool 11th annual master's course here for over 8 hours. We had a heavily francophone, meaning French influence, with Professor Jean Dubussy, Drs. Abitbol, and also Vincent Arlette from UPenn there. But we had a great faculty, and for over 8 hours, we hit mainstays in spine, and we had over 500 views. So we thank all those who've been part of that. The videos of this will be released in the very near future. Again, I'll introduce Dr. Lord later, but for an initial contact, Liz, can you hear us?
Yes, loud and clear.
And we hear you loud and clear as well. And there you are. Good morning to you. Thank you for joining us from LA. As always, we have a couple of cases. There are no curveballs in there. We try to select cases that kind of fit to the theme. And the theme is learning and learning points in terms of how to do surgery. We have two great faculty members here also from Tacoma. Drs. Cavey and Martin are here, and I'm going to pass the microphones to them also. But we'll bounce some cases off of you. And the first one is going to be presented by Dr. Cook, and it's a case of mine, and full disclosure, it's a complication of mine. I've practiced over 30 years. So I'll be curious to hear how you would have handled it, and we'll see the input from our colleagues. Dr. Cook?
All right, I'm Jared Cook. I'm orthopedic spine fellow here. So our first case, the patient comes to us, a 54-year-old male with low back pain radiating to the bilateral lower extremities for 3 months. So at that point, he is seen by another provider outside the system, and they order an MRI. MRI's results come back, and they're referred at that point to complex spine. Patient doesn't have any bowel or bladder dysfunction, saddle anesthesia, weakness. Medical history is significant for type 2 diabetes, but it's very well controlled. Liver cirrhosis, no longer drinks, BMI over 40, and does have thrombocytopenia. So the whole issue here is pain. So what I'm showing you right now is X-rays that were taken a month prior to the MRI that he got. These were read as normal. The lesion that's apparent at at L1 was missed. So right over here is that lucency that we can see. It was read as normal though. So the MRI that the patient got that prompted the referral was this one here. So we see significant destruction anteriorly, and then in the posterior elements, the left pedicle of L1 is completely destroyed. There's involvement of psoas paraspinal musculature.
So let's stop there for a second, Jared. So Liz, thank you again for joining us, and formal introduction will come later. Is it just up here in the Pacific Northwest? Is it our center, or is this something that you see in LA with a major referral center like UCLA Health certainly is, that we're seeing sicker patients with more neoplastic lesions than ever before that come with all sorts of medical strings and comorbidities attached?
Yes, absolutely. I am seeing more and more, especially with some of these immunotherapies and CAR T therapies, people who are living and frankly, I'll get into some of the calculators for life expectancy longer and longer, but with, platelets in the 20s and, unstable spines. And in medicine's like, they're cancer free, they're stable, they're going to live forever. And then it's a very difficult, conversation to have to someone who's in intractable pain about whether or not, surgery is truly going to make their life better, or, significantly worse. I will say though, if you look back at that X-ray on the AP, it does appear that there's a sign there, this winking owl sign. If you look at it, one of the pedicles does appear to be missing, and that's, something I always count the vertebrae, and I always look for bilateral pedicles. But if you look really closely there, the pedicles do appear asymmetric at L1.
On that note, how do you handle, what's your advice in terms of this kind of a gotcha situation? So here we had an X-ray that, Jared, was half a year earlier, something like that?
No, this was only a month before.
Oh, a month earlier, but it was totally missed. It wasn't an outside facility. How do you handle that? Do you call them? Do you write that in the notes, or?
I wouldn't know if I'd call this missed, to be honest. I mean, this is incredibly subtle, and this is that's a hindsight thing, sort of, seeing the lucency on the lateral and knowing where this is going. But I've certainly had cases where I've, seen something, maybe hemangioma, and then later it's definitely not a hemangioma. I think these are some of the human and potentially AI also sort of issues, where everything is clearer in hindsight and we all just do our best. But I wouldn't call this a miss. I would call this a hindsight pickup.
Okay, that's a good word. I put that in my armamentarium. Jared, remind me later in clinic, hindsight pickup. I like it.
Okay.
So the next question I have is Oncologic. This is, again, something we have our annual tumor symposium that Rod and colleagues have put together for how many years now, Rod?
It's 11 years.
11 years,
Yeah.
like the master's course. And we debate this endlessly. So this patient is neurologically intact, but he has easily, right, Jared, 90% canal compromise at his conus level. He's somehow still functioning. He has severe pain. He's laying in bed. He's a big guy, but he has thrombocytopenia, pretty significant. He's a former alcoholic. So what do we do in that setting? Do we biopsy and wait, or do we just say, look, at least again, in our neck of the woods, biopsies nowadays take a week, sometimes longer, to get all the immunology out. And what are the therapeutic consequences? Do we just do an angiogram? What is your thought in terms of an oncologic situation where we don't have a clearly manifest neurology? The SIN score is what, Jared, roughly? You calculated it?
Blanking on what his was. I feel like it was like 13 or something.
SIN score is about 13, so that usual kind of
Here, let me find it. It's right here.
Yeah, indeterminate. Yeah, indeterminate, clear. So not particularly helpful, maybe. So do you wait for a biopsy result to come and keep them in the hospital for about a week plus, at least for our pathology response time? Or do you just say, let's do an excisional biopsy, let's move?
Yeah, so if they're neurologically intact, I can tell you definitively, being here at a sarcoma center, it is critical that you don't just dive into this and you actually stage it for a number of reasons. One, this could be an extremely vascular lesion. And so any type of incision could cause, not just, worsening of neurologic function, but also potentially exsanguination, especially with those platelets. And secondly, if this is a Ewing's or something, it might not end up requiring surgery at all. And if it's a sarcoma, other than Ewing, something that it could be potential, it may not this one sort of goes from the front to the back. So this one, I don't think you could actually take out en bloc and spare neurologic function. But in some other circumstances, you can take something which is completely curable and really change that patient's prognosis, which we see, I see not infrequently. So I would definitely recommend, in the absence of any significant neurologic deficit, and many neurologic deficits can be modified with steroids, high-dose steroids in the hospital. So I'd absolutely wait for a biopsy. And as I'll get into it, potentially, if your pathologists are not super strong at some of the unusual stuff, sending it off to a sarcoma center if we don't know what it is. And then, of course, doing the regular staging, CT, chest, abdomen to help us.
Yeah, so we did stage him, and there were significant liver lesions found. I'm going to look to my colleagues, Drs. Martin and Dr. Covey, whoever wants to take the microphone. So full disclosure, it's a complication of mine. For those who've watched this, I think about a month ago, we've shown this case before. It's a complication of mine. I wish I had consulted Dr. Lord first. What is your thought? So you have a neurologically intact guy. This is a very uncomfortably high-grade conus compressive lesion. The guy can't get up, but he's not objectively by any differentiated exam retaining urine or having any neurologic deficits. Do you wait for a biopsy? There's no fracture. He's not really braceable. He's too big for that. Do you do something excisional? How do you move forward?
I would agree. Waiting for a biopsy makes sense. I mean, you gave some pointers here, so I think in some situations it might take a week, but if you talk to the pathologist, you can typically speed things up. If it's something like a lymphoma or myeloma, you get your report pretty quickly, typically. So, and of course, by this time, you probably already did a CT scan of chest, abdomen, and pelvis. Might have given some indications too.
Jared was
Right after MRI, that's part of our
good.
workup.
So yeah, so we did a full scanning workup.
So MRIs of the full neural axis, there was nothing there. CT, chest, abdomen, pelvis, dedicated, CTs of the involved areas, so thoracic and lumbar spine. So I'll show you the lumbar in just a second. There were lesions throughout the patient's liver. It was presumed hepatocellular carcinoma at that point. Let me just kind of run through these real quick. So here's the lesion that we're seeing on that lumbar spine CT. Here's a SIN score. As I said, it was 13. And so at that point, and then, also, labs is, did SPEP and all that. So at this point, the biopsy was done. We had the rest of the staging workup. It was shown to be hepatocellular carcinoma. And so then here's, what we did with it. Or if anyone hasn't seen the screen, you can weigh in and say what you would have done. So
go back to the CT, Dr. Lord. So we have a biopsy. We suspect this hepatocellular carcinoma. Again, do we do an angio first? Do we now say, look, somehow this has to be resected? He's not fractured yet. And if you want to do surgery, what's your surgical suggestion?
So I do tend to embolize most things. I trained with Francis Hornacek, who told me, he never regretted embolizing anything. In terms of angio, this is be a little low for Adamkowitz, and as I'll kind of go into later, I haven't found that in primary cases that's been a significant issue in terms of just a one-level corpectomy. So I would say if you have the time and IR availability, I frankly embolize everything. HCC isn't the bloodiest in the world, but you don't lose much by doing it. So I would do that essentially in the same setting or the day before as the surgery. And then in terms of surgery here, HCC is really not super responsive to radiation per se. There's some new immunotherapies. I would definitely do a stabilization, and corpectomy is sort of plus minus here. But if I were to do it, I think you could do either lateral or posterior, and then but you'd also need a debulking essentially posterior. I'd probably go lateral just in terms of getting a bigger end plate cage there.
And how many levels above and below?
I think you could just do, I'd check the Hounsfield units above and below, but I think you can definitely do one if the bone is strong enough, one above and below. You can do two if you want, but I think one is fine.
Okay. Let's pull our colleagues from Tacoma. Dr. Covey took the microphone first. Dr. Martin, what do you think?
I would definitely embolize this just due to his history of thrombocytopenia and his liver disease. My experience has been that those are the worst bleeders, and I've had some unexpectedly trying surgeries for folks who just won't stop bleeding. So I think anything to ameliorate that would be helpful. So I would definitely embolize. It seems to me like it needs some anterior support. So I would, anterior support, and I'd probably go two above and two below, so that I would never have to, or the chances of having to go back and operate on them in the future would be lower.
All right, I love Dr. Lord's suggestion because I had a complication here. Dr. Askuian, any thoughts on the decision-making and what you've heard?
No, I think obviously in retrospect, we probably should have done a couple things differently, but yeah, I think it was a good plan going in.
So I appreciate the endorsement, and again, take us forward to my ongoing learning curve.
So the plan was a two-stage operation, starting posteriorly with the debulking posterior fixation from T11 to L2 with cemented screws, and then partial corpectomy, and then stage 2 was a lateral corpectomy. Resected the rest of the tumor that was able to be resected, and I guess I forgot to write that there was an embolization prior to the second stage in this one, or attempted there was an angio, no embolization.
And the embolization, the angio did not show much in terms of vasculature,
No, it
surprisingly.
So this was the construct. After both stages, the patient was then able to get up and start mobilizing till post-op day 2, as having significant low back pain during a physical therapy session, and then was suddenly unable to mobilize, whereas he could before. So a new CT was ordered at that point, and this is what we saw. So L2 had fractured. We got cage subsidence and rotation as well, and then what we're seeing all the way in the image on the right, that's at L2, and basically just what's left of pedicles after the screws had pulled out.
So that was pretty disappointing for me. We had thought about what to do. We did a cement augmented fixation. I love to hear that you said one above, one below. Thanks to my wonderful colleague with great far lateral skills, Dr. Skuyan, I've become more audacious with doing short segment fixation. I was always trained in 2 or 3 levels above and below, and relying on the large cages that can be put in with enormous end plate offloading capabilities through far lateral procedures. And again, this is very nicely done by Dr. O, but that L2 vertebra blew apart in record time, and again, pretty frustrating for me. So we did check the Hounsfield units beforehand. We carefully looked at that vertebra below, that L2 vertebra, and we did not detect either metastatic disease. I forgot what the HU measurements were. They're recorded in my charts. 143. So the HU references were not terrible. In retrospect, I could have put larger screws more anteriorly, but maybe it was just a badly conceived surgery from my end. Any thoughts from your end, Liz? So here we have a blow apart, which maybe fortunately happened very early, but still very frustrating because an oncologic patient, we don't want to waste too many bullets.
I mean, again, this is a minimally invasive surgery. We're talking about trying to minimize blood loss on someone, platelets 67, or presumably supplemented, but still low platelets, thrombocytopenic. I think this is a good surgery for them. I don't know if there was potentially any end plate violation, maybe because 143 that's a great number. I think sometimes things happen for reasons we don't always know. But the only thing I could think of here, if you've got good end plate coverage there, I think that's a good case. I don't know that going 1 down would have prevented this, 2 down. I don't know that going another level down would have changed this.
So yeah, thank you for that. I was not expecting you to say just go 1 above, 1 below. That was music to my ears, but this is not scripted, by the way, so I appreciate that. But I was obviously having significant second doubts then about my decision making. The first surgery was pretty not trivial. I think we lost about 2 liters of blood, and doing more would have probably been more challenging. I don't like to go past 2 liters too much. You mentioned, Liz, tumor board also in your chat room. We have a weekly tumor board, and I don't know how helpful that is. I think, Rod, what are your thoughts on our tumor board? How does that work in our setup here?
I mean, it's challenging because they're kind of a different perspective. Like, they don't look at stability, instability. They occasionally will talk about tumor biology, but it's almost like, the main question is how much radiation, and do you get IMRT or do you get standard radiation is kind of the big debate.
How helpful is it for you at UCLA Health to have a tumor board? How operational is it for you in decision-making for spine patients? Because here it's very cranial heavy.
Mhm.
And, again, we have plenty of tumor cases for the spine, but how's it for you?
So the tumor board that's very functional here is our sarcoma board, which I think is invaluable because, I'm not an oncologist and I don't have training in the biology of these tumors. And so I really do rely on my colleagues in medical oncology, radiation oncology, and my orthopedic oncology colleagues to supplement that for me and tell me, what's best, because I can't, for sarcomas, the decision-making is so complex and it changes every year and there are all these trials going on. So for sarcomas, honestly, I think it's mandatory. And I would really strongly recommend that if you're, in the community that and you come across a sarcoma, to really consider at least getting a second opinion or sending it out to a tumor board, because it can really change the lives and outcomes for these patients. In terms of metastatic disease, we've tried to do a spine-specific tumor board. It is challenging because of the time sensitivity of these things. And again, as you kind of allude to there, radiation oncologists don't always understand the mechanical issues in the same way that, surgeons do, and their priorities may be different. So that the metastatic tumor board has definitely been challenging. I think the context this person was asking about tumor markers and neoadjuvant therapy in terms of the biology, especially as an orthopedic surgeon. I know neurosurgeons like to do a lot more kind of global patient management, but as an orthopedic surgeon, I do stay in my wheelhouse a little bit of being a surgeon, and I do leave the the decision of like total therapy in terms of how much radiation and what type of medical oncology to my colleagues in those fields.
Yeah, and I want to thank Dr. Faiz Ali Shah for his question about tumor markers and neoadjuvant therapy, and I think it was a great answer by Dr. Lord. With our colleagues in Tacoma, how does that work for you? Is the tumor board helpful in your decision-making in a hypothetical case, if this is yours? Does that help you in your decision-making and management, or is it, again, just too much of a detached world?
I think one of the things, of course, the vast majority of these patients are metastatic disease that we see. And the difference probably now with 15 years ago is that at that time, all these patients were admitted to the oncologist. And now they're typically admitted by the hospital service. And the oncologist oftentimes sees the patients after we've seen the patient. So it's, whereas initially most of the referrals came directly from an oncologist, who knows the patient's history or can give you the workup. Now, you don't typically have that. So it's the inpatient service that says, oh, we have this patient with cord compression, and they haven't done much of a workup. So it'd be, that's the difference I can see. And that's, of course, a loss because they have the oncologist involved from the get-go is very helpful.
All right, so Liz, here I've had a complication, and what do we do now? How do we move on? So this patient has a lot of pain. He's a big guy. There's an anxious family hovering around. It could be in LA. How do I navigate that? Do I just barge ahead? How do I communicate? How do I communicate to myself?
So, hopefully with these, there's been extensive, preoperative counseling about all the risks of complications. I did have a mentor previously tell me in fellowship, oh, don't get too into the complications, you'll scare everyone off. I have the opposite view. I tell patients ahead of time, there's I tell them every complication I can think of. And then that way, when it happens, they're like, oh yeah, you did mention that. So hardware failure and fracture is certainly, a known complication of this surgery. For something like this, I think, again, the sooner the better it's addressed. This person, again, needs to sort of start the oncologic treatment for their metastatic disease. They need to be stable and then heal from their wounds so they can start that. So in this case, that cage is subsided, so it's not doing much in terms of anterior support, and there's no vertebral body left there, so that needs to be rectified. And then with that sort of coronal and sagittal split, I think there's not much left in that two body. So I think you just need to go bigger now, unfortunately. This is a big person, BMI 40, not easy. Hopefully that it's the incisional bed there isn't too scarred if this was less than a week out. So I think you need to go bigger, and this time I would go 2 up, 2 down. And I'd be really, really tender with the end plate prep there, you know, kind of not do too much expansion of, I mean, the cage doesn't look over expanded, but just be super ginger with everything there. I don't know that putting a plate on the side is really that much extra stability. I do worry about the screws causing fractures. So I would basically just go bigger.
And do you want to predict far lateral surgery? Can we put a 2-level corpectomy cage in through a far lateral exposure through one of those elegant X-lifts?
I think you probably want to go pre-psoas here. But I believe you can. I believe I haven't personally done it, but I believe they can expand, I mean, significantly. I just don't know if it starts small enough that you can get through the plexus there. So I'd probably, I mean, at 1-2, it'd pretty kind of easy enough to sort of cheat the psoas, you know, posterior and do sort of like a modified lateral where you really go in, you know, not a true O-lift, but, you know, through with 80% of the psoas and all of the plexus behind you, essentially. That'd be a lot more challenging at, you know, 4 or 5.
All right, Jared, let's take us forward. We've chewed on this long. I don't want to look at these images anymore.
So that is what was done. So 3 up, 2 down. Did the corpectomy of L2 and removed the original cage. And there was nothing scarred down. We were only only a few days out. So this was a 2-stager, but it was done 1 day after the other. So posterior was taken care of first. Got those L2 screws out of the way of the cage coming in. That modified lateral where the psoas was behind us was utilized. It's actually went in pretty well. Although this is basically, that cage is basically the size of the retractor. So it just got in there. But it honestly wasn't too much of a struggle. And then, we're very careful with the end plates. And then here's, kind of our end sagittal. Like immediately afterwards.
One thing I've noted, that looks great. I really like the extra, I think there's a 3rd rod in the back.
4th.
So yeah, love that. And then one thing that this is, the CT looks fantastic there on the lateral X-ray. Something I've run into too is the limitations on the lordosis of these end plates. It can be limiting at times, which we'll talk about in my last case. And so it looks great on the coronal, but something that I think these companies need to work on is really, as we do more and more of these and patients are expected to live longer, is really getting more lordotic end plate options.
So this is a learning case for me from the more recent past. Rod, what are your thoughts? So first I want to thank Rod. He's a phenomenal far lateral surgeon, always a great colleague to bounce complications by. When I have a complication, whatever time it is, he is always there when I can always call him, and I want to appreciate that also. But in terms of the technical skills, how difficult was it to use your X-lift, your far lateral approach to do a 2-level corpectomy?
Actually, it was 3 levels.
3 levels, sorry, yeah.
It's, I think the plexus, I think Elizabeth pointed out, we were a little bit above it, but really the only limitation I think we had was the getting the implant past the retractor, because the retractor has only so much that it'll open. And then I've actually done a 4-level corpectomy, and you have to use a different cage. And then I had the fellows retracting manually with malleable retractors. So, I think because of the location, the plexus wasn't easy. The surgery was fairly recently. I think the difficulty was because we had a smaller incision, is just getting down, I think it was down to L3, just getting that end plate and then not trying to, just stay within the cavity. But it really, I mean, Jared, you were there. How long did it take? Like 2 hours at the most?
Yeah, something like that.
Yeah. So, I mean, it's incredible. All the device companies now have these expandables, and they're getting better and better. And it was fairly straightforward.
And Dr. Lord mentioned the lack of lordosis in some of those larger cages. So was that an issue? Is that something that's being addressed?
Not there initially was, but these have lordotic end plates, and I can't remember, this one had 4 degrees on each one, and but then we switched it to, I think the top one had. And then now they
The
have
top one
the,
was 8.
is it 8 degrees? Yeah, I think it was 8 degrees total. But now they have these end plates that pivot, so.
Talk to us, Dr. Lord. You have a major tumor center there. You do oncologic surgery about all these new radiolucent implants. Should we have used carbon fiber, whatever, bio devices that are less pingy on radiologic or radiation oncologists' endeavors?
I think that's a really good question. In my practice here, and when I speak with my radiation oncologist, it is nice for them when they can do their planning if they have some scans without any hardware in there. But in terms of in my practice and here in general, the true value of these implants, which are typically carbon, is really in the surveillance as opposed to the initial radiation. And for something like a metastatic disease, the surveillance is not as significant, or this is metastatic disease, so functionally the cat is out of the bag here. This patient is going to need chemotherapy and probably immunologic therapy, and so this is likely a disease that is treatable but not curable. When you're talking about something else, a disease that's curable, and a recurrence would be a new disease. If you were to miss a recurrence based on some hardware artifact that could potentially be life-changing, that's when I'm using carbon. So I really exclusively use it for my sarcoma patients and my sarcoma patients who do not have metastatic disease, frankly.
And how long do you wait for radiation? How long do you wait for chemotherapy in patients like this? And when do you restart anticoagulation in patients like this?
Yeah, so for platelets in the 60s, that'd be a real discussion with oncology and hematology, and I'm not sure how much anticoagulation that patient would need. I do like to get filters as well in these patients. I think they're extremely high risk for both clotting and bleeding. So I do like to get a filter in this kind of patient, and they probably haven't been moving too much. In terms of resuming chemotherapy and radiation therapy, I tend to do that around the 2-week mark, or at least when they're healed. Some of the immunologics, if they've already been on medicine ahead of time, can really slow their healing rate. And so I tell them, I want the incision to be a scar, not a scab. And, even if it is, I've had, especially, I check the albumin, but I've had wound dehiscences at 6-8 weeks from MIS, perc thoracic screws, just because of the healing issues with some of these immunological therapies.
I agree. Our colleagues in Tacoma, so Martin Covey, any thoughts reflecting on this case? You were voting for waiting. Does your hospital allow you to keep a patient in the hospital for a week or two until you get all the data together, or what are the learning points for you as you look at this?
Well, yeah, we don't get much pushback because they're typically not real facile at managing these things anyway. So that's not, excuse me, that's not an issue. I think that your complication was just an unfortunate event. This is a very challenging patient. I noticed that there was some ankylosis up in the thoracic spine, and I wonder if that long lever arm above T2 or L2 with just a single level screws might have just doomed it. But it's a great save. As far as waiting, I agree with. I'd like to make sure that the staples are out and there's a scar there, that there's no question that the incision is healed and the tissues are healed before instituting RT or chemo.
Great. Thanks for the discussion, everybody. Jared, any other thoughts on your end? So far, the patient's doing great. We, by the way, sew these up with nylon. We do a 4-layer closure, and we leave the nylon stitches in. We just about Senna tattoo on this side, do not remove. And we get incessant calls despite that when can we take the stitches out? And we basically say 3 months. We have had the same issues, and we put them on a high protein shake diet right off the bat. But Jared, any thoughts on your end? You're intimately involved with the patient.
I think in hindsight, going 2 up, 2 down, makes sense. But given the initial presentation, I would not have thought that this sort of failure would have happened with the initial construct. I don't. I don't really think anything was, was wrong, and I don't think that a future patient, like it would be wrong to treat a future patient with the same initial construct, because we've seen those work plenty of times. This is actually the first time I've seen that that construct fail in this manner. It's hard to individualize like that. I think that's the lesson you come away with. It's hard to individualize. You can't predict everything.
Yeah, great. Thanks for that discussion and presentation, Jared. And Jared is going to leave us soon. He's finished his fellowship here, and he's going to go to Virginia Beach. So thank you, Jared. Next, Dr. Chris Seidel, and he's done a great job with his fellowship. He's heading to the end of the year. He's hiding his hair loss from his overwork with a nice cap. You would not allow that with your trainees in UCLA, right? They couldn't run around with a cap like that.
Let's see, I haven't seen it yet. Let's get him on video.
The camera's on me, good. Well, Dr. Seidel is gonna, here's Chris. So good morning, Chris. Tell us about your case. This is again a patient who's had a different form of a complication that did not come from in-house, but that pertains to decision-making in elderly patients.
Yeah, certainly a challenging case that is becoming more and more common. So this is a 73-year-old female, past medical history. She's got neuropathy, chronic pain on long-term baclofen. She's bipolar, heart issues, immunologic stuff going on, history of a DVT. Going back in time, so she's status post bilateral L1, 2 and 2-3 laminotomies, and then unilateral L3, 4 and 4, 5 from October, which were in trying to treat her initial problem of severe bilateral buttock burning pain. So you're thinking probably L5. That was unfortunately complicated by a post-operative epidural hematoma, which had to be evacuated, and a subsequent wound infection as well. Now she is presenting to us, and she's complaining of continued back tightness, bilateral buttock pain still, hypersensitivity. Now her thigh pain, she's having thigh pain that wasn't there before. Her functionality has just been declining. She's unable to stand for longer than 15 minutes or walk very far. On her exam, it's mostly, again, L5 type symptoms on motor testing. The sensory was really non-dermatomal because of her peripheral neuropathy. And then obviously because she's complaining of this thigh pain, she's probably got some degree of L2-3 radiculopathy going on. She did have an injection at L4 bilaterally transforaminal, which gave her, I think, about 40% relief. Here are initial Scully films when she came to see us. So obviously she's got that hip replacement there on the right. She's got a fairly flat back, spondylotic, pretty much throughout the entire extent. You can see a pacemaker up there as well. Here's her CT, again, preoperatively. She's got some post-laminectomy stenosis, consistent with her kind of neurogenic claudication type picture, multi-level spondylosis with disc-based collapse, loss of lordosis, as mentioned. Also, there was a mention in the notes that she had a persistent pseudomeningocele from a CT myelogram, but I was unable to locate that CT myelogram.
So the point is here, this is an elderly patient who has a pretty significant disease burden. In the discussion of our oncologic patient, we did not talk about disease burden measures, whether it's following the NOMS criteria, whether it's following a Karnofsky index. You mentioned nutritional panels. We might, and this is a discussion point I want to just raise here. So this is an elderly woman. She's fairly intelligent. She's had some mental health history problems. She has a nice family around her, but she just cannot function anymore. She walks significantly forward bent. She basically uses one of those wheeled walkers to kind of hunt around. She's mainly a household, quote, ambulator. And surgery was done at an outside facility. One attempt was made as a decompression. It is listed as multi-level. Not sure how much there was. There's a CT myelogram that we sadly couldn't download for this presentation. But she had a very bad post-operative course at that outside facility. So she had a hematoma, and then I think there was an infection, and there was a documented CSF leak. She was, I don't know how long she was in the hospital, but she was in the hospital for quite a while, and it was a pretty traumatic event. So here we're now caught in this fracas of a patient who can't have an MRI, by the way, because of her pacemaker. And she says CT myelogram. She is clearly not well decompressed. She clearly has neurologic symptoms. There's an overlap of a myriad of things, neuropathy, this, that. And there's a disease burden also, an undeniable significant disease burden. So for tumor patients, we have quantifiers, we have decision-making tools. Where should we start with the decision-making in an elderly patient who has greater functional aspirations than what her spine allows her to do? Liz?
Yeah, that's a good question. I think some of these frailty indexes have been trying to address this in terms of quantifying how, well, it's really more the complication profile of these patients. It doesn't necessarily tell you what interventions to make, but at least you can quantify someone on an index and have some indication of their likelihood of complications. And it sounds like this woman has like a 300% rate based on her previous complications. So, you know, for me, the way I'm thinking about this is I at least, you know, get some sort of prompts to see how disabled they are. It sounds like she's, you know, severely disabled. I would definitely check, you know, to make sure we're talking about back or leg or both to really understand what my goals are for surgery. It sounds like she's primarily leg. And then this is a tough case. If she's functional otherwise and healthy otherwise, which is hard to get a sense for, you know, some people with that background can look at you and be well-dressed and well-groomed and supportive family. And other people like that can be disheveled, and you look at them and you're like, this person's not going to do well, with the exact same, you know, sort of description. So I think there's a gestalt essentially, but clearly this is operative, and, you know, 70s is not as old as it used to be. So I need to use more of the frailty index, but I would have some sort of quantification for how sick and how capable this person really is. And then I would get the myelogram so I understand where the issues are. And, you know, there's a lot going on here. So I'd go through this level by level and really try to tease out which, you know, where her symptoms correspond to the pathology here. Because to me, scrolling through this, it looks like there's something at every level.
That's good conjecture. You talked about a tumor board before. Do you have a multi-specialty weekly or monthly spine board that looks at these kind of ethically and medically and surgically challenging decision-making cases?
We have a weekly indications board where we go through all of our cases, but I do informally go through more complex cases where the decision-making is more complex, you know, more sort of second order. Informally with my colleagues. Something like this, I would probably not sign up for surgery without discussing it with at least one colleague.
So yeah, just verbalizing this. So she has severe stenosis from L1-2, L2-3, all the way down to the previous surgery zone where there's, it looks like a mess on the myelogram. I mean, there's no real dye passage. Literally, it's a pan-lumbar disease process with something substantially wrong at every level. I'm just verbalizing the myelogram here, which we sadly couldn't locate. So let's ask our colleagues. Jos, Mike, do you want to talk about this? So this is, again, a literally weekly occurrence in all of our clinics nowadays. Elderly patients that are elderly, they're pushing the microphone around. Nobody wants to answer this. They want something done. We know that we could help them, but the surgery would probably be a very major surgery to have clear complication. Dr. Lord quoted a 300% complication rate. There's a huge investment from the healthcare system, from all of us, emotionally, knowledge-wise, OR time-wise. There's a significant resource utilization afterwards. Undeniably, this patient will need extensive care. How do we verbalize this? How do we operationalize this? Do we tell them go somewhere else? Do we punt? What do we do?
I think the comment that was made by our guest lecturers is the of leg versus back pain is important. I mean, if it's clearly more neurogenic claudication and ridiculous symptoms, I might be tempted to just focus on a decompression and ignore her postural issues. completely. I think, the chances of her really falling forward with a more appropriate decompression is probably not that great, and that would be a manageable surgery if her expectations are realistic. But if it's a big postural issue and back pain is more predominant, then laminectomy is not gonna.
Yeah, I'll have to verbalize that. We actually have, that's a cool thing here in our EPIC system. We have integrated PROs, so patient-related outcome scores are in there. We have an NDI, an ODI, and the PROMIS scores all in there. And she was very disabled. I forgot what it was, but it was both back pain and leg symptoms. So they were indistinguishable. And I forgot what her ODI was, but it was in the heavy disease range, 68 or something like that. It was miserable. So, Dr. Lord, so here we have a mess. You've gone to a weekly indications conference. You've had your great colleagues there to bounce this by, and everybody says like, oh, that's bad, but good luck. I don't know. So what is your suggestion now? How do you want to proceed? Do you want to venture into surgery or not?
So someone like this, I would agree with my colleague there speaking. So I would probably, in all honesty, especially with the history of infection, I would probably start by doing the laminectomies. In all honesty, I do think, with that foraminal stenosis at 5'1", I don't know if I could really do that without a fusion, honestly, because it looks pretty tight. I think they need some height restoration through the disc space. But I would probably see what we could get out of doing purely the laminectomy, just unzip it all the way down, really go after that lateral recess. And then if I didn't get a ton out of that, I would probably, or she wasn't happy with the outcome, I'd think about doing probably an MIS deformity here if they still needed it. And I think, she corrects here. I don't have all of her parameters, but, she's got some lordosis at least when she's lying there supine. So a lot of this might be her, forward sagittal profile might be driven by that stenosis itself. So that would be my initial recommendation, is to just decompress this, see how she does, and then potentially do something MIS deformity-wise for the second stage, if and only if it's needed.
I want to recognize Dr. Pirzad, Ahmad Fazad Pirzad. Thank you for joining us from Afghanistan and the Afghanistan Neurosurgical Society. And Dr. Farag Bash points out that there is a sagittal imbalance. It's not profound. I forgot what the parameters were. They're all listed. 6. But he felt that a laminectomy alone would probably fail. From my end, when I have this post-laminectomy mess with wide femoral things, I don't know how to repeat decompress that. I can't certainly isolate any single levels. This is as I said, a pan-lumbar disease. So Dr. Oskoyan, you've been through, and as Chief of our Spine Service, you've done a great job with running a multi-specialty indications conference that kind of was destroyed by COVID. What are your reflections on having a decision-making panel to kind of go through the technical and multi-specialty decision-making points in a complex case like this?
I mean, I think they're very useful, and I think a case like this is a perfect example of why you need to have that conference. The difficulty with all these conferences, and when you get down to the nitty-gritty, is who's going to take care of this patient afterwards. That's ultimately the difficulty. Usually the primary care doctor or physiatrist would be ideal, but just given the degree of stenosis, it's a very difficult patient population to deal with.
So again, I'm going to pin you down, Dr. Lord. What do you want to do here? Do you want to do MIS? Did you want to do a decompression? There's input. We had a literally international panel. We have a colleague from Libya, so Dr. Al-Khadafi, fantastic to have you here. Most people want to do a fusion, and we have Dr. Basim Ishak from Heidelberg. He wants to do an L1 to S1 revision decompression and fusion. And he said, will be painful, we'll take the whole day. So are we going to do the painful all-day surgery and revise L1 to S1 and fuse probably T10 to pelvis or something like that?
Yeah, I mean, I don't disagree with that. I think that's the definitive surgery here. I think, again, in order to really decompress L5-S1, the foramen specifically, that would need a fusion in my hands. I don't have the technical expertise to debride that anterior osteophyte there. but again, I push back a little bit about the fact not all sagittal deformity is driven by a structural issue. Some of it can be driven by people leaning forward to decompress their severe stenosis. So in a case like this, especially if I had any question about whether the infection was healed, I would potentially unzip this, do an open lammy midline, really clean things out definitively as well as I could, knowing the 5-1 frame and it's still stuck, and then potentially see how they do. And if that doesn't cut it, then doing the fusion, which again, not knowing her household units, et cetera, you know, this is just looking at the bone. I'd imagine this is someone who needs a couple months of an anabolic agent, so they're not ready to go for that anyway.
So a question comes in a second, but in these kind of cases, I never do surgeries very rapidly. We actually get to know the patient. We try to optimize them, and this is a multi-month, and I forgot how long it was in her case, half year or a full year preparation
at least
or more.
A full year.
Yeah, we try to prehab patients and have a fairly nice program for that. I want to credit Dr. Dave Hanscom for having started that here. So we have a bullet point list and the whole clinic is engaged with that. It doesn't always succeed in terms of patient compliance, but we try to be fairly concise about this. Now, here's the question, and that's risk management. You talked about a 300% complication rate. In your experience, how good are patients at understanding risk? When you tell a patient you have a 300% risk, they'll go like, well, I'm the fraction of a 1% patient who will do well with this. I mean, this is my experience. You can tell them 300% and it's like, it doesn't even matter. So how do you kind of get risk to patients? Should we have a directive medical system where we are ultimately the ones who say yes or no, or should patients have autonomy and be part of the decision making?
That's an excellent question, and I don't think I can answer it. I will tell you, for the riskiest and most complication-prone surgeries I do, which would be sacrectomies, I sit with those patients for, I mean, hours. I have, like you're describing, multiple preoperative visits. I not only go through the literature, but I say, like, you are going to have a complication. Like, you're going to have a known complication, and then you're going to have an unknown complication, something I've never even heard of before. And then when they get it, they're like, you told me. It doesn't necessarily help them emotionally, but intellectually, they can think, you know, I did hear this before. And that's hours of my time getting them there. And that's really the chordoma, the, you know, deformity patients. This patient, I'd have that talk with her too. And I think it's important because something is going to happen here, you know, not 100%, but, you know, 95, even if it's just UTI.
Good. Rod, do you remember this patient from our pre-op discussions? What was your thought on what we should do? I mean, this is obviously a medical mess, a psychological mess.
I think you're right. I mean, I think most patients, when you tell them the complications and the risk, it just goes right over their, you know, they don't even think about it. So.
All right, so let's see what we did. Drum roll. We have 5 minutes and then Dr. Lord's lecture will come.
I didn't include it here, but she's osteopenic, not osteoporotic.
Oh, really? Good.
DEXA's range, the Hansfield units range from about 110s to 130s. So we elected to do a complex revision to get her completely decompressed from the junction all the way down. We did inner bodies at 4.5 and 5.1. Then we instrumented with a quad rod construct from TA to the pelvis. And obviously during this, we unearthed that pseudomeningeal, so there was a dural repair that was taking place. Post-op CT.
So we basically placed our eggs in the bottom 2 levels to get maximum lordosis, and we used a quad construct. And I hope you have the standing films on her.
Yeah.
And how long was the hospitalization? How long was the surgery? Dr. Ishak said all day.
Sadly, this was before my time here, so I'm not sure. I'm assuming it was all day.
It was 8 hours, I think, easily. And she was in the ICU for several days. And I forgot the hospital stay, but I don't remember any complications. Am I having protective fog?
She had a persistent pseudomeningeal despite extensive repairs of the dura, but she seems to be doing okay from them.
So now let's go to the long-standing films.
Yeah.
So, and Dr. Ali Shah said sometimes when you inform patients about the complications, they'll say no to the surgery. We try very hard to be very clear about our risk And again, sadly, I find it almost an exception of patients saying, no, I don't want surgery. It happens, but I usually find the patients to be optimistic and almost ignorant to even the most dire and clear complications. So, okay, so she's about a year out now. Where are we?
Yeah, so she's improved in several factors. The low back pain is gone. Some of the butt pain is better, but it's still there. She still has a little bit of aggravated symptoms with activity, but her balance is improved, posture is improved, and she doesn't have any more falls. So definitely better.
So the interesting thing here is, so in terms of back pain, she actually says, I have no back pain. She gets buttock burning when she stands, as Chris pointed out. But I was actually impressed. She has literally no back pain, and she wobbles when she walks, but she's standing straight now. So she uses my favorite trekking pole, so she's gone from her wheeled walker. In the end, again, this is exactly what we thought. There's a huge investment of time. She was in a skilled nursing facility for, I think, 3 months. She had a persistent kind of a fight with what was like a pseudomeningocele, but we did not have to take her back to the OR. I think we just managed her with fluids and a lumbar binder and proning. We avoided a repeat surgery. She had no infection, but again, it's interesting. You didn't put the PROs on there, the graph PROs. Yeah, it's very interesting because they actually look very good. But when I see her, she's still wobbling. She feels great in terms of she has no more back pain. It would have been nice to put the pre and post-op sagittal images together because it's a nice restoration. Is it worth it? So I'm going to ask Drs. Martin and Covey, is this worth it? There's a huge effort. We made a discernible improvement. If you went by ODIs, we are like 40 points better. That's not an exaggeration. But she still needs her walker. She doesn't need a walker. She uses trekking poles for longer distances. Who decides that this is better, that this is worth it from a societal investment?
Wow, societal is hard to say. I mean, we practice individual medicine, right? We use statistics and we look at things, but ultimately, I think we're practicing individual medicine, and it sounds to me like it's a success. I mean, with those outcomes, if your patient-reported outcomes are that high, then that's a success by any measure. Yeah, I think I would have just done the laminectomy and hoped for the best to see how she did personally, but boy, you can't argue with that success. I just have one comment about the discussion. It's frustrating for all of us that folks don't understand numbers. You know, I have patients that come in and tell me they have 100% back pain, 90% right leg pain, and 50% left leg pain. So there's clearly a disconnect on their understanding of statistics. But I think the process of talking to them in depth, and especially in this lady or with Dr. Lord's sacrectomy patients, whether they remember the specifics or not is, I won't say it's irrelevant, but other positive things come from that. And one is an understanding that this is not magic, right? This is a process and that we're working hard and bad things can happen in spite of everybody's best efforts. And I think most importantly, it gives them the feeling that you actually care about what's happening to them because you're spending that much time with them and going over these things. While they might not be able to verbalize it, at some level, I think patients understand that and appreciate that and are more likely to be accepting of the bad things when they happen because of that.
Closing comments on this case, Liz. We showed this intention because, again, this is a major hall, and these kind of patients are literally ubiquitous nowadays. So any closing comments, words of wisdom on this?
I think this looks fantastic. You know, you took the time to counsel this patient and prehab them. The alignment looks great. More importantly, the PROs are great, which is difficult to achieve in someone with that many medical comorbidities. So I really applaud, you know, the workup and execution of that case. A great outcome.
But it was a lot of work. So thank you for being here today. Thank you all for your contributions and our global audience for their input. It's such a privilege to have Dr. Elizabeth Lord here this morning. She has a unique background. She was born in DC, but raised in Egypt and Kenya and abroad. She did her medical school at Georgetown. She did her internship at WashU. She did her residency at UCLA. She did a multidisciplinary fellowship at NYU, and she is now on the faculty at UCLA for several years. She is, I'm very beholden to her great work as a deputy editor for Global Spine Journal, and she's been a thought leader in many arenas for us in our spine community and orthopedic surgery. She has given us a great topic, learning curve, euphemism for complications, and how we basically instrument or work in complex deformity situations and challenging clinical situations as a surgeon and as a young surgeon. I consider myself a young surgeon because I showed complications of mine. So thanks for being here, Liz, and it's great to have you with us, comment on our cases, and look forward to learning from you.
Thank you for having me. Let me get my slides up here. All right. So thank you for having me. I'm thrilled to be here, and thank you, Dr. Chapman and Dr. Seckin, for having me. It's been a pleasure working with you both in our various capacities. So I'm going to be speaking today about starting off as a new surgeon. This is really directed towards the fellows. I think, for me at least, coming out of fellowship, you're so eager to get your hands in and get dirty, and everyone's like, oh, just, do everything. But it's not an easy time for anyone. And, you're lucky to have each other and be at a fellowship with other fellows. So really, bounce things off each other's and your mentors there. Because this is people walk around like everything is fine, but this is a very difficult time. Complications are going to happen, and it's critical that you find this professional and personal support to get through that. Here are my disclosures, none of which are relevant. So I'll be going through quickly just some general advice to begin, and then some case studies of some of the challenges that I've faced. So in terms of oncologic issues, a couple of sort of pearls here. Something that I use routinely and have my residents do for every case is go through what's called the SORG, the Spine Oncology Research Group, or protocol and algorithm. This is something developed out of MGH, I believe, and basically it's predictive algorithms for survival. And so, when you've got the patient who's BMI 15, albumin 1, platelets 30, especially with HCC, they often get these portal and splenic vein thromboses. The patient's there with kind of a reasonable, they can converse to you, but they're just like not healthy, and they're going to potentially die on the table or, be unable to be extubated. And so it's good to have sort of numbers when, medical oncologists like, oh, they're going to live forever, life expectancy 5 years, et cetera, to plug it in the algorithm and say, look, I want to help this patient, but I want to help them spend their time on earth, not dying of spine surgery. And so this is a good way to really quantify, how long does this patient truly have? That's not just speculation based on medical oncologists who can be a little optimistic sometimes. In terms of solitary bone lesions or massive bony invasions, if we kind of touched on this earlier, but if there are no neurologic deficits, you should biopsy. I'm an orthopedic, surgeon, and I know that there's some discussion here in terms of, neurosurgeons come from a different background, but truly there is a difference in terms of the treating and outcomes of this between metastatic disease and sarcomas. And if you sort of get in there and muck up a sarcoma, this can really take something that is curable into like an incurable quagmire. And some things like synovial sarcomas, if you poke them, they actually get worse. So it's really critical to understand what you're doing. And then in terms of, BMP usage, we know now definitively that BMP does not cause de novo cancer. However, if you put it into an existing cancer, a cancer bed that's already there, that is legally pretty indefensible. It's arguable, whether or not the patient's going to live long enough to develop or worsen that cancer, but legally it's indefensible. So really just don't do it. Those patients have a challenging fusion situation anyway. So you're not really going for fusion. You're really going for solid instrumentation just to get them through their treatment. Moving on to deformity pearls, you really can't overplan this. I use I guess some of these pre-planning softwares where I do pre-contoured rods, and that helps me think about everything level per level. What are my goals per level? I think about, for myself, Do I want age adjusted? Am I going for Rousseli versus, Schwab? So it really just helps you define what your goals are, and then you can also measure and see if you can achieve them. Again, we've touched on this in this talk. You can't over counsel on risks. I tell them, 80% of patients are happy they did this and 20% aren't. And I tell them if they have pre-op depression, I'm like, that's the biggest risk factor for not being happy with this. So I go over this over and over again, and whether they get it or not is, that's beyond me, but I really emphasize this. And I talk to them about neurologic deficits, especially with osteotomy. I think it's studies have shown early career surgery, this is going to happen, but this is 20% risk. That's the ISSG data. So it's a real risk, even in the best of hands. And I would ask you if you have good reps. One, if you don't have good reps, to find them and really make them your right-hand people, because they understand what's going on in the cases, and depending on who your staff is, they may or may not. In terms of patient management, I'd recommend saving lists of your patients in your EMR. Depending on your EMR, you can add them. And so this way, if someone's readmitted for something, you'll see that it's there. I had a patient who had T4 to pelvis who I saw show up, and they had a hip fracture. And like the surgeon who operated on them didn't tell me, but I happened to see it because they showed up. And so it's important to, maintain that relationship with patients if they come into the hospital for something else. It makes you seem very thoughtful if you know this. Then also if, they pass cancer patients, as well. You have to do talks like this. If they're categorized, you can also find them. And then in terms of, structuring your setup as an early surgeon, where you are matters a lot. I'm in a very competitive spine market, which is makes my practice growing more difficult. However, I'm also at an academic institution, which has a broad referral network. So there are over 200 spine surgeons in LA and growing every day, but patients do Google searches. They're going to look you up even at the very beginning of your career. They're asking how long you've been doing this, et cetera. And so it's important, if you can, to make a website have some sort of presence. If you're in an academic medical setting, it's not going to be so easy. Like, this is mine, and this is UCLA Health. I could have a separate one, but I'm competing with people who are like Hollywood money, who are making really, really nice things out there. So for me, I really rely heavily on the referral network that I get. And in terms of patient reviews, I ask them to fill out patient reviews. I need to be more aggressive about doing this. It's super awkward, but when you get those patients who are bringing you, it's a gift or something post-op. So, the biggest gift for me is to leave me a positive review online. And it's awkward. It's a weird conversation. You can have your MA or whoever's checking out do it. But it does work. So this is an example of somebody you can see here who's got, this person is, I think, 5 years into practice, which 134, 5-star reviews. I know this person because they told me to ask my patients for reviews. And then here we have, a world expert who is in the same ballpark of review wise, and not to knock the other person, but, asking for reviews matters. Like, being aggressive about this can make a difference. It's not just your reputation. So moving into my cases now, this is my first example, which is a legal example and not necessarily deformity or tumor, but this is a 44-year-old patient who had a history of ACDF 5-6, complicated by pseudoarthrosis there and adjacent segment disease, who ended up getting ACDF at 4, 5, and 6, 7, and presented to me with neck pain. He was healthy, no immunocompromised. And interestingly, he actually was initially referred to a center across town with Jeff Wong specifically. However, their insurance company said that that's not a center of excellence, but my facility is. So the patient ended up coming to me after they were already booked for surgery with literally the former CSRS president. Well, I'm like 6 months into practice. So this is the construct. You can see the sort of low and broken screw from the initial pseudoarthrosis, and that level has healed. But the 2 other levels, based on both the measurements and then also on CT scan, had not healed. Those were pseudo, so likely the source of the patient's neck pain. And then they had a little bit of stenosis up at 3, 4, but nothing, not horrible, but there was something there. So my plan for the patient was to back this up posteriorly rather than going through the front for a 3rd time, and then do the C3-4 laminectomy for amniotomies for that sort of, upper level neck pain and the central stenosis there. So this is immediately post-op. I thought everything looked fine. The case didn't take that long. There was nothing intraoperative that I noticed. However, this patient woke up absolutely screaming with hand pain, intractable hand pain. And this is what his hand looked like. You can see the IV marks. So what had happened was Anesthesia had placed an A-line, if they're like A-line, like whatever, healthy 44, I try not to argue, or I tried not to argue at the time, but essentially they had an A-line, which, arguable, should they've had it at all, probably not, in this space. And so the whole time, if the arms were tucked, it was pulling. And so it essentially caused a compartment syndrome in this guy's hand, 4-hour case, but this thing was like yorking on it the whole time. So luckily I'm in an academic medical center, and I do know, my hand surgeon is across the street operating. So we were able to get this guy back to the OR. He couldn't consent, but the wife was there for the fasciotomies within 2 hours, thank God. So that is, I was losing my mind over that, but that seemed to be fine-ish, However, on post-op day 2, that's on the left hand. On the right hand, and he's right hand dominant, he starts to have weakness in his interosseous muscles. No sensation, no pain issues, but weakness. And so we get scans, all the screws look fine. This is delayed. Post-op, he was totally fine, and it was documented in the post-op check that the right hand was fine, and post-op day 1. Check everything, screws look fine, there's no pre-op foraminal stenosis there, no post-op foraminal stenosis there. There's a little signal change here at 3-4, but what is that causing his intrinsic hand weakness? Maybe, nothing happens. So I decided this was a CAT1 redic, and that ended up being the case. This is a good global spine journal article, essentially, which differentiates that between ulnar nerve palsy. Initially, I think anesthesia someone had posited this is a cubital tunnel, but his arms were extended during the case. They were tucked. So it wasn't as though he was flexing up like this, or even like this. So that's a good article if you're ever confused about it. Basically, it's the thumb. So I did steroids, hand occupational therapy, prayed a lot on this. I spoke with everybody I knew at the time about how to treat it. And essentially, this was the consensus to wait it out. It didn't get a ton better. It went from like 2s to maybe 3s or 4s. The EMG did show that there was this denervation. Again, they're calling it bilateral, but essentially right greater than left. The left was fine. So he really didn't get that much better. And by about 6 months, I referred him to one of my hand surgeons here, Neil Jones, who came up with like the toe thumb transplant and ended up doing a bunch of tendon and nerve transfers. But he started missing follow-ups. And this is during COVID, by the way. So I operated on him in February 2020. So in terms of the follow-ups, most of this was remote. He lived about 100 miles away. So started missing follow-ups. He filed an intention to file a lawsuit. I guess there's like a warning sign that you get. No deficits in left hand, but the claim was weakness, pain in the right hand, and his wife also filed essentially for loss of companionship. This did end up being something called dismissed with prejudice, which, as I learned, means that they can't sue you again. There's no like mark against you. But this was like an incredibly traumatic experience. I didn't end up getting deposed or anything, but this was very difficult to go through emotionally in my first year of practice. So the lesson learned from this, is that, well, one, I did actually end up later at conference speaking to Dan Roos specifically about this. And he says, if this does happen, go in the front and do an aggressive foraminotomy on that side. Even if you can't see it, it could help. Obviously I wasn't keen to take this guy back for a 3rd surgery, especially when no one at the time told me that. But now if this happened, I would. But, risk is inherent to every surgery. Be thorough, document the risks. If there's a complication, do not sit on it. I would get to know your vascular surgeons, your ENT surgeons. Hand is a little out there, that shouldn't be happening, but, vascular and ENT certainly. Lawsuits, they happen. If you talk to anyone, any of your mentors, many of them or most of them have been sued. Anyone who you speak to about any complication can be deposed. Which is a plus and a minus. So many people say, don't talk to anyone about this. It's a threat to you. I sort of took the opposite tack, which I don't know if is wise. I basically talked to everyone about it because I wanted to get the best care for my patient and source opinions. So I was like, look, if they wanted to pose like the 25 people I've spoken to about this, all of whom say, it happens, there's nothing to do, that's fine. But it's definitely challenging. So if that happens, make sure you have your, personal support showed up. And, don't talk, you want to talk to the patient, but you don't want to say anything incriminating, essentially. So next case, this is my tumor case. We have a 59-year-old who had a poorly differentiated synovial sarcoma treated back 10 years ago at the time, 15 years ago. And she'd had an intralesional, which is not the way to go for these, vertebrectomy, and then posterior spinal fusion. So this was done again outside hospital. It wasn't done on block. It was just done at the time. And like I said, once you cut into synovial sarcoma, it can worsen it. But in any event, she'd been followed, followed by our sarcoma center sort of since that was done. So there was a new lesion seen on PET. She was asymptomatic, though. It was just found on surveillance, and she's a smoker. So this was the initial case there. You can see it was done a while ago, so they didn't have the same type of anterior column support. And on this one, I mean, I can't see the lesion here. It's at, I believe, T10. Then if you'll note on the sagittal there, or the lateral, she's also got an isthmic spondy at 5.1. So here's the lesion, pretty subtle on CT scan. I believe it was picked up on a PET though, so it had some type of, or a contrast CT, so you can, it's there, but incredibly subtle. Again, if I were to miss this, I don't know, on a de novo patient, I don't know if it'd be like a miss or something seen in hindsight. Here it is again, but again, in the setting of a known synovial sarcoma, you would take something like this a lot more seriously than if it was in another patient. But just in terms of this not being a hemangioma, you can see the irregular borders, how it's not well circumscribed. That would be my clue that this is maybe a little bit something like this. If I were to see this alone and someone without the history, I would definitely I presented to tumor board, but I can tell you the outcome from that would be, close 6 month, 3 to 6 month follow-up with and without. And then here's on the PET, you can see the lytic agent to it, but not super enhancing. So this is, she's a T10 lesion, biopsy proven recurrence of synovial sarcoma with a prior C7 to T6 posterior spinal fusion. She has mild DJK, but again, asymptomatic at the time, and she had L5 pars defects. So our plan, because unlike the lesion that was shown earlier today, this is really contained in the anterior vertebral body. So in those cases, it is possible to do an R0 on block of these type of cases. And so that was our plan. And then extending down to T1. Again, did decide to go long on her, but not, again, we know that she's got this L5 pars defect, but no back pain at this point. So the technique that, I like to use in the thoracic spine is described by my mentor, Francis Hornacek, which is a single stage all posterior. And essentially you can read the article, it's in JVJS, but essentially you thread these tomato saws anteriorly and you thread them in between the great vessels and the vertebral body. And then you saw from back to front in order to create the osteotomy. You do that again through the disc above and below typically, although you can do it through the vertebral body. And that's a nice way essentially of getting the whole vertebral body out in one go, and you sort of rotate it around to get it out. There are other techniques as well, but this is a nice single stage way to do it. So during this case, which again is not a revision at this level, this is a revision, but the T10 level has been untouched. After we didn't embolize it and didn't check a Damkowitz. We done the laminectomy, and we were passing the saws and we'd taken the segmentals, and it was right after we took the segmentals that we lost MEPs bilaterally. And then as time went on, we also lost bilateral SSEPs. So at this point, the cat's sort of out of the bag. We've done everything that, we've already taken the segmental, we've passed the saws. Is an oncologic case. It's not like we can reverse the correction or anything. We raised the map, we went through all the algorithm, but there's nothing else that you can do at that point. And I hadn't really, patients always ask, am I going to get paralyzed? I usually tell them, extremely unlikely, not impossible, but then I'm like, but not really. And maybe I shouldn't have said that. If you tell them they're going to get paralyzed, or there's a real chance they might not do the case. And again, it's tricky with these oncologic cases, because this is something that, she's already had 10, disease-free years because her tumor was taken out, so this is something that could really change the course of her life and her life expectancy by operating versus not operating and doing the right surgery, which is an unblock. So it's tough on what to counsel them because you don't want to scare them off, but you don't want to not counsel them appropriately either. So in any event, we lost signals. I was freaking out. At the time, my boss, who was in the case with me, who was an oncologic surgeon, was like, oh, this happens all the time when we do it at T10. If it's a, not a reoperated spine, it's totally fine. This just happens. We're going to write it up someday. So here's the vertebral bodies that we took out. You always get an intraop x-ray. Here's the construct. We plugged it into the top one. Again, quad rod there. And post-op, she had absolutely no deficits. She woke up being like, I'm in pain. I regret having surgery. I hate you, but 0 deficits. So I was like, thrilled. I was like, this is the absolute best outcome. I love this. I don't care that she's in pain. I was like super excited. And she hated me. She was like, if I'd known I was going to be in this much pain, I never would have done this. How dare you? So I thought this looked, pretty reasonable. Again, because I wasn't using carbon screws at the time, but we did use a peak cage actually so we could check it out more easily. I don't love my screw angle distally there. It could be a little bit more parallel to the end plate, but not small, not short. But it did not stay there. So as you can see, she had DJF pretty early on. I think this is like post-op month 2, roughly. And so this did not help her pain situation or her sagittal imbalance. So I was really upset during the case, losing motors like that. I felt like I had sort of talked her into surgery for the survival benefit, and then we paralyzed her. But I was lucky to be with a senior mentor who was like, it's fine if it's not a revision. And I guess that's true. This was sort of the only time that's happened to me in thoracic case, and I've done a couple. So I'd be curious, Hornacek and Joe Schwab say they're going to write this up at some point. I hope they do, because I'd like more information on that. But at least in revision settings, if you're going to go back in around a dam coeds, 1, I'd know where it is. And 2, I would counsel them that you can definitely get paralyzed in a revision setting. For primary, I don't know, maybe not. So my last case is, and she to this day hates me. And she ended up getting a revision in private practice down south, where they did like L1 to S1 A-lifts with BMP in the lumbar spine, which would not be my case of choice, but she did need something here. This failed, and I think with the L5 spondy going to pelvis is reasonable. So that did help her back pain based on what I've read. So my final case is a 65-year-old woman who had a T10 to pelvis at Outside Hospital, again, many years ago, 12 years ago, who fell into a ditch and basically been able to stand upright ever since. Smoker, but otherwise kind of reasonable history, lives alone with a dog, importantly, but other than depression, pretty healthy. So her, she can walk with a walker, but is stooped forward. I don't have any clinical pictures, unfortunately, but these are her x-rays. She's standing in the middle one, and then she's sitting in the AP to the far left and to the right. So you can see the kind of issue there, that the rod has fractured. This is, again, 12 years post-op, but she had a fall. And so we can kind of trace what happens here. I was able to get some of her old x-rays. So, I didn't have her PI at the time, but, looks pretty reasonable there. Nice fusion mass. And then you can see here when it started to break, and this speaks to sort of, putting someone off and having to find them, the right surgeon to take care of them. So it sort of progressed over time. She was getting MRIs. You can see there the psoas are incredibly dysmorphic. You can see how they're, at 4.34 and 4.5. This is in my hands, not somebody to be comfortable, doing a lateral on, although this could be potentially tasty for that if the psoas look different. So again, she's sort of like scooting around LA trying to find someone who's going to take care of this, actively smoking, and it's just getting worse and worse and worse. And so this is, by the time I was finally able to get her, I saw her and I tried to direct admit her, but because she had this dog, she wouldn't go into the hospital. She had to go home and find someone to take care of the dog. So finally I got her into the hospital, and by that time she couldn't sit up. So again, this is to the planning. I do like to plan extensively. This was my plan for her. So what I ended up doing is I extended her up. You can see here, she is PJFing as well. What happens is, again, as her sagittal imbalance worsened and she started tipping over, it's a cascade essentially. So although she was not PJKing before this broke, she did PJK because of the delay in getting her aligned. So I had to address that as well. So we ended up going up higher in the back. I did a tether, again, poor bone quality. And then I tried to go in the front, and this is what I was speaking about, these cages, because of that psoas, like we didn't have a great corridor there. So in terms of the width, I couldn't get a nice big end plate, which I obviously would have wanted. So I ended up having to use the most narrow cage, which is an ACDF cage. And that did not have the same kind of lordotic options. So I ended up basically hand sculpting a piece of iliac autograft, and threw that in there. And then again, I didn't have a big corridor, so I just threw in a ACDF plate. That's why the screws are so short. It's the max length for those screws. And I put 4 rods in the back. I wish I'd done, 6. But alignment wise, I was pretty happy with it. I mean, she went home, not to rehab, post-op day 7. Like, she is hard as nails and really loves that dog. So the issue now that I'm having is that, I'm worried about this. It's not, you can see the crest there in the front. I put a lot of BMP in there. But with this, she's smoking again. I don't know how that's going to really incorporate, or if I'd call that true anterior column support the way that we're used to it now. I didn't have any harms cages on hand. We don't keep them in stock, and I thought I'd be able to put an implant. So it's definitely jury rigged. Got a foot drop, doesn't mind, continues to smoke, refuses to follow up. Again, she's like, I'm not driving into LA traffic. And so I think this is going to fail at some point. And I tell her that, I'm like, you need to come in and get x-rays. This is at some point going to fail again. Like, I just want to put 2 more rods in, but I can't make her, essentially. And I'd love actually some wisdom from you guys as an early career surgeon as to how you prevent these people from, sort of falling off the map when they feel fine, but there's something brewing. So there's a lot to learn, is my number 1 lesson. Thank you guys for your attention, and I'll take any questions you might have.
So this is an outstanding talk, and in terms of honesty and wisdom, very motivational and inspiring. So thank you for that. I saw a great question in this context by Dr. Ali Shah. As I look around, I don't like social media too much, but I'm on there. I see a lot of fora on social media and Facebook. There's several LinkedIn groups and Twitter where they literally have some groups that do votes on what to do for cases. Kind of interesting. What are your thoughts on social media presence, posting cases, either in good or for decision-making help as a virtual kind of a decision-making board?
I think that's a great question. And I think actually Dr. Deepti Jain did a great presentation on that for Seattle Spine. The most important take home for me from that was to really understand who your audience is or why you're posting. So are you posting for your colleagues to sort of build your network and advertise that way, or get case advice? Because that's a different audience than if you're posting to direct to patient consumer. And so I can tell you, for direct to patient, those might not be the patients who you want to see. They're not worked up. They don't know if their back pain is operative or not. And you do have to, or are you posting because you want like a side hustle? You want to be a social media influencer and essentially monetize that. So I think first, before you decide, you need to figure out why you're posting. And then that will drive, if you want to go direct, if you're like on TikTok, people on TikTok don't have a lot of back pain, right? That's young. But if you're trying to tell people how to get into med school, then it can be helpful. So really define what your goals are before jumping into that.
So Dr. Al-Gaddafi also thanked you very much for the presentation. I think everybody's very much in awe. Complications. How do you handle complications? Do you have a network for that? Do you just have one another? What's one of your take-home points in terms of how to navigate setbacks? You have that signal loss. You have these patients who are non-compliant, where it's a disaster brewing, and you still do it. So what are some of your reflections on what you just heard by Dr. Lord?
It was very honest, and honestly, I've been doing this for 30 years, and those are lessons for all of us at all times. We're always learning. We always have something to learn. So thanks for sharing that with us. But that won't go away. You'll always have to deal with that. What was the?
So take-home lessons like decision-making, how do we handle complications? Can we find solace in colleagues? Should we kind of seek more mental health professions? Can we rely on the system to provide support?
I don't think we can rely on the system to provide support. That hasn't been my experience. I rely heavily on my colleagues. I talk to Yoss, I talk to other folks in Tacoma, I've talked to Jens. Ask for help, ask for advice, do it early, do it often. It's important to have a supportive family. It's lonely in the operating room. People don't, who don't do that, don't understand. I mean, you don't know in the middle of that case that everything's going to turn out okay. You explain to someone like, well, everything turned out okay. I'm like, yeah, everything turned out okay, but I didn't know that at the time, right? You don't know, and your mind goes to all these other places. So if you can take some advice from an older surgeon, try not to go down that rabbit hole intraoperatively. Concentrate on what you have to do, concentrate on finishing, doing the things that you know and how you've been trained. That'll help you get through it, and then deal with the consequences later. But having a support, the people that you work with is important. I don't know how you can do something as complex and involving as what we do and not have someone to help you.
Yeah, well said. I thought those cases were fantastic in the discussion. Rod, any thoughts?
Yeah, I mean, those are great cases, Elizabeth, and it's a very humbling profession. And, I think the first year in practice, you did some very difficult surgeries, and I commend you for, just kind of reflecting and showing, your complications. I think that's an important part of the process. There's kind of two ways to deal with it. I think a lot of surgeons bury their head in the sand and kind of, they don't acknowledge that this is like our reality. And I think that's probably not a good way to deal with it. So,
yeah. I want to echo that. So talking about complications honestly helps not just us and having a network, but also helps society better understand the gravity of what we're doing and not seeing it as a commodity, which is, I think, one of the biggest challenges in our society now. They see a lot of surgeries as a commodity, expect a perfect outcome every single time. And spine is the most gratifying and spine is the most humbling of all professions I know. And this is why I love it. And this is why there are days where I absolutely hate it. But then having colleagues like you, like Rod, like Yoss, like Mike, who I can talk to very honestly is so helpful. So having this network is huge, and having a forum where we can talk to one another honestly without fear of depositions and adverse discovery efforts is super important. So any final thoughts from you and Liz?
Thank you for your time. It's been an honor to present.
No, yeah, fantastic cases, great insights. And as you can see, complications never stop. I started the whole day with a complication of mine that was recent, and the learning never stops, as Mike Martin said. So be well. Thank you so much. Fantastic presentation, fantastic commentaries. Yeah.
Thank you.
Take care.